So I have 4.402, so I'm gonna go ahead and get started. So first and foremost, let's go ahead and scan the QR code and sign in. I would really appreciate it if you watch it on from YouTube or watch it live right now. Please scan the QR code and sign in. And today we are going to cover burns, a pretty interesting topic, and it is one of the material that will be covered in your third exam of MED-SURG 2. There will be a question about burns in the HESI2, especially the calculation part, and also the treatment when the patient is experiencing burns. So with that all being said, let's go ahead and get started. First, we have a burn is damaged tissues caused by heat, chemical, electricity, sunlight, or nuclear radiation. So the most important three that we would cover and really focusing on today is the heat, the chemical, and the electricity, the burn that causes from those three factors. So usually burns can be caused by scalds, fires, flammable liquids or gases, and even, like I said earlier, electricity and chemical as well. So what are different types of burn injuries? We have thermal burns, chemical burns, smoke inhalation injury, electrical burns. Specifically, we have to monitor for ABGs because of the risk for metabolic acidosis. And why does it lead to metabolic acidosis? We will discuss later. And electrical burns can also cause damage to the kidneys. Lastly, we have cold thermal injury. So even extreme temperature, very cold, can also causes burns injuries as well. So first, we have thermal burns. Thermal burns is scalding injuries, usually caused by fires, and these are like the most common burns that we usually experience. And chemical burns are whenever we contact with acid or organic compounds, like all the liquid or the flammable liquid from the lab or from a refinery. Smoke inhalation injury, the most common one is carbon monoxide. This is it's not carbon dioxide, it's monoxide. This is usually produced whenever there are smoke during burns. Also noxious gases, hot steamy air, like when we take bath. These can develop airway compromise and pulmonary edema. We also may see mucosal burns, which would have the characteristic of redness, blistering, edema, swelling. It is rapid and massive. So remember, burns to neck and chest makes breathing difficult because eschar get ties and constrict mobility to breathe. So whenever we have any type of burn injury, and if it's around the neck area or the chest area, and especially around the neck area where the airway is being damaged, the tissue there, when it get burned, it will get necrosis. And eschar is the result of the necrosis tissues. When there's no life in the tissues anymore, the eschar tissues become very tight and rigid. There's no more constriction or dilation of the muscle or contraction of the muscle, and therefore, if we have a burn at the neck area, it can lead to the difficulty breathing and also airway obstruction, which is really dangerous. Next, we have edema in the face and neck is lethal. Like I said, whenever we have the burns area, even though if not leading to necrosis, causes eschar, like tissue death, but it can also causes edema, like whenever there's an injury, as an inflammatory process of the body. There will be swellingness, and which is the edema. And if it's at the face or the neck area, it can obstruct the airway, and that's why it is lethal. Pulmonary edema can happen within 12 to 48 hours after the burns. So we have to look for signs such as singed nasal hair, hoarseness, painful swallowing, burnt clothes around the neck and chest area, and then assess the patient, assess respiratory. So if there is exam question that she give you guys these signs and symptoms, these characteristics such as singed nasal hair, like the burned nasal hair, or the patient complain of painful swallowing when they just escape from a burn or having a burn injury, we definitely need to look at the respiratory and assess their respiratory to make sure that their airway is not being or will be occluded. And finally, electrical burns. So electrical burns is the one that I would like you guys to focus on as well. This will be on the exam. I think I remember there was a question about electrical burns during my third exam. So electrical current will directly damage nerve and vessels, and strong muscle contraction from shock can break the bones. So electrical burns can cause us severe muscle contraction that is so strong that could result in the break of our bones. This can also lead to tissue anoxia and death. If needed, stabilize spine if fell from height from the shock. Patient is at risk for dysrhythmia and can cause cardiac arrest or VFib because the electrical current is so strong and it causes contraction of the muscle. And also remember that the heart is also a muscle. So if we have a strong electrical burn, it can lead to the super severe contraction of the heart, which can lead to cardiac arrest or alter the rate that the heart beat, causes dysrhythmia and lead to VFib, which is also very dangerous as well. The patient can also go into metabolic acidosis, the and have myoglobinuria in urine, which causes acute tubular necrosis because of the blockage in the kidneys. So what does that really mean? So the reason why electrical burns lead to metabolic acidosis and can increase risk for acute tubercular necrosis is because it breaks down muscle and release myoglobin, which is accumulate and overwork the kidney. So myoglobin, whenever the muscle, the electrical current from the electrical injury or burns damage the body, the muscle is being break down, which can release a substance called myoglobin. And this myoglobin is very acidic, which then it can lead to the metabolic acidic in the body. It decreases the pH level of the blood, and also because it's accumulate in the kidney and the kidney cannot effectively work, and therefore it leads to acute tubular necrosis. And remember in the kidney tutoring, I said acute tubercular necrosis is the most common cause for intrarenal injury. Okay, so just a link there. All right, next, pathophysiology of burns. So before we cover that, whenever we experience or someone experiences the burns, they can lose the fluid very easy. They can have a lot of edema because whenever we burns, the tissue and the blood vessel is being damaged. All of the substance inside the blood vessel got leaked out into the local surrounding area. Therefore, it leads to loss of fluid, first of all, and also edema and swellingness of the inflammation process. Because of the leakage and the loss of fluid, the patient can experience hypovolemic shock. this can also lead to further decrease more the intravascular volume. And you guys know whenever we decrease the intravascular volume, it causes a decrease in blood pressure because there's no much blood anymore to push. So that's why the blood pressure also goes down whenever the blood volume goes down. So also not only because of the leakage of the fluid, but the blood volume can also decrease because of the third spacing. Like I mentioned earlier, because the blood vessel is damaged, all of the substance is leaked out of the blood vessel, and these substance include albumin. Whenever we talk about third spacing, we remember the substance albumin, which is a protein, and because the albumin is leaked out of the blood vessel, the fluid follow the albumin leads to further decrease in the intravascular volume. So now we have a ton of fluid in the wrong space. The fluid not inside the vascular system, but it inside the surrounding tissues, which means that we have swelling and dehydration, swelling and hypovolemic shock. All right, so the hallmark that we need to remember is the low blood pressure, high heart rate, high respiratory rate. This is the perfect combo that always goes together in the first 24 hours. And then the patient will also experience urine output decrease. The reason for this is not only the kidney is being damaged due to the decreased blood volume, lead to a decrease in perfusion. So it decreases the effectiveness of the kidney, but also there's not much blood to go out. So that's why the urine output decreases. And the body also try to hold on to as much fluid as they can because it senses that we lost too much fluid during the burn injury. So initially when the burn occurs, we will have increased vascular permeability. It means that the fluid, the plasma, the protein leaks out of the vascular system, the vessel. All right, increased vascular permeability, meaning that this, for example, my hand is the blood vessel and the skin around it is the barrier. During burn, the barrier have many holes in it, which increases the permeability of the substance inside my hand. So all of these substance inside my hand will release through all these holes, and that's what it means by increased vascular permeability. The fluid volume moves out of the vascular system and into the interstitial space. The patient will blow up swollen like a huge balloon, and they have a lot of edema, a lot of swellingness, but internally, intravascularly, they are hypovolemic shock and dehydrated. The volume inside the vessel decreased significantly, therefore lead to the blood pressure to drop significantly as well. The decreased volume lead to an increase in hematocrit. Why? So when we talk about volume of the blood consists a lot of components in it. It have red blood cell, white blood cell, platelet, and also other substance as well. So when we decreases the volume, we lost a bunch of them, including the red blood cell. However, the percentage of the red blood cell in the blood remain increasing because it's, I don't know how to explain it super well, but it's like we have these solutes in the blood, and those are red blood cell, and the volume leaked out, but the solute still remain inside the blood vessel, which is the red blood cell. So therefore we have increased the hematocrit. Hematocrit is the percentage of the red blood cell, not the percentage of the volume of the blood. So we have decreased volume, but increased hematocrit. And hematocrit is the percentage of the red blood cells. So it will lead to blood viscosity, which means that the viscosity is the thickness of the blood. Like when we lose too much volume and we have only a little bit of volume left and a lot of red blood cell in it, it makes the blood really thick. And eventually it will lead to increased peripheral resistance and lead to shock-like stage, all because of increased vascular permeability. All right, I hope it makes sense so far. All right, so we have classification of burns. So the severity of burns is determined by the depth of the burn, how far it reached into our body, the extent of the burn, the location is very important. Remember, if it's neck and chest, it's very easily can lead to airway obstruction, and those are lethal priorities that we have to focus on. And then patient risk factors. So if the patient is elderly or infant, they are at higher risk for experience more injury from the burns. So we have different depth of the burns. We have first degree burns, which is called partial thickness. It's affect the epidermis of the skin only, and these usually are sunburn. Second degree burn is superficial partial thickness, and third degree burns is full thickness. So death is the first, second, third, fourth degree burns. I don't know what that means. The extent of the burn is the total body surface area. You use the rule of 9. And what is the rule of 9 and how to calculate the extent of the percentage of the total body surface area? We will discuss in a later slide. Location influence the severity of the burns. Burns on the face and neck and circumferential burn on the chest or back will interfere with breathing, and there is an obstruction from edema, and then the leathery eschar make it hard to breathe. So again, face, neck, chest, it can lead to issue with breathing. And what does it mean, circumferential? Circumferential basically means that it not only burn only the anterior, but also the posterior as well. For example, this is the anterior part of my arm. Circumference would be the anterior and the posterior as well. It's like the whole circle thing. And the reason why circumferential burns is dangerous, because if you guys think about it, say my arms like this, the muscle, it can constrict or it can dilate. If there's pressure inside, the arms can get bigger, but with circumferential burn, the tissue around this arms is dead or eschar tissue, so it's very hard and rigid. So the pressure, there's no way for the pressure to escape. So that's why it can lead to the pressure is so strong that it can lead to obstruct the blood floating from into the arm, so it can cause the whole arm to die, or my hand to die, because the obstruction is right here. It's like what is it called? The compartment syndrome. Awesome. Thank you so much. You read my mind. All right, so burn in facial area can lead to obstruction of the airway due to the swelling and edema. Increased capillary permeability causes fluid shift out of the blood vessel and result in hypovolemia. All right, so again, the decrease of the burns. First degree is partial thickness, involve the epidermis. Second degree is partial thickness, that have two different kinds. Superficial is the thin wall fluid filled with blister, developed within minutes, and deep partial thickness, which is secondary burn, is the entire dermis, appear waxy and white. Third degree burn is full thickness, involve destruction of the epidermis, the dermis, and often the subcutaneous tissues. Sometimes we can see the bones, muscle may also be destroyed. It will be dry and lethargy. Okay, so remember the hallmark of these. So if she talk about the patient's skin appear to be dry and lethargy, we know that that is a 3rd-degree burn and that is a full thickness. If the patient's skin is waxy and white, that would be deep partial thickness, which is 2nd degree. And if the patient's skin is, there are fluid-filled blister, it will be superficial 2nd degree partial thickness. And if it's like a sunburn, it will be just like a partial thickness of the 1st-degree burn. So please study that. This is just another picture that you guys can use to cover and learn for the 1st, 2nd, and 3rd degree of the burn more visually. All right, so we have the rules of knives. So let's focus on my note because I think it's more updated and it's more correct. So the reason why we need to calculate the percentage of the total body surface area of a person who got into a burn injury is because this number will be used in order to calculate how much fluid we will need to give to the patient. So percentage of TBSA is used to calculate how much fluid we will provide to the patient. Because if you guys can recall, patient experienced burn, they lost a lot of fluid. So first, if the patient have an anterior burn on the anterior head and neck, it would be 4.5%. If it is circumferential, the whole head, it will be 9%. Anterior arm will be 4.5%, and the whole arm will be 9%. Front trunk, which is from the neck to the belly, would be 18%, and the back trunk will be 18%. So therefore, the whole trunk is 36%. Anterior leg, the front appearance of the leg will be 9%. So therefore, the whole leg will be 18%, and the genital area is 1%. And again, circumferential burn is all the way around. This will be on the exam, like 100% sure. Like I am so sure that it will be on the exam, and she will give you guys the calculation of this, and then she will also give you guys a calculation of how much fluid we need to give to the patient. So, for example, if the patient, if she give you guys a question, something like this, let's do a little question together. Like if the patient experience burned circumferential right arm, anterior left leg, front trunk. So, oh shit, what did I do? Oh my goodness. Sorry, guys. So I said earlier is circumferential left arm. Thank you. Anterior right leg. Front trunk and genital area. So for example, the patient has burns in this area. What is the total percentage? What is the total percentage of body surface area equal? So circumferential left arm we know that the anterior arm is 4.5, so the circumferential left arm would be 9%, right? So 9% left arm. If she asks circumferential both arm, it will be 18. But here in the question is circumferential left arm. So it'll be 9% and plus anterior right leg, it would be 9% as well because, yeah. And then front trunk is 18% and then generator is 1. And then this is the total percentage of TBSA. All right. So this is how we are going to do it. Easy, right? So please don't miss these questions. All right, this is just another picture for you guys to easier study. All right, anterior leg is 9%, not 4.5. All right, location of the burn. So severity of the burns is determined by the location of the burn wound. Face, neck, chest, respiratory obstruction, so think airway. The patient will experience wheezing, anxious, may need to intubate. Hand, feet, joint, eyes, self-care issues. So if they have burn injury in the hand, the feet, around the joint, or eyes, we will need to focus on self-care issues. If they have ears, nose, buttocks, and perineum, they will have higher chance of infection. Circumferential burn of extremities can cause circulation problem, which can lead to compartment syndrome. Assess circulation, pose, cap refill, color, and temperature. Really message one. All right, now we have phases of burn. So pre-hospital, we have to remove the patient from the source if we see that the patient is experiencing burn. However, if the patient is experiencing electrical burns, please don't just use your hand and take them out. Use a wood stick or something that pushes them out of the source. Electrical burn injury, usually we have to make sure the the cervical spine is stabilized. We then do EKG to make sure that the heart arrhythmia or dysrhythmia is not lethal. And then we have to consider for metabolic acidosis. Because why? Because of the breakdown of the muscle lead to the release of the substance called myoglobin. Chemical injury, we get rid of the chemical to get off the skin. If the chemical is dry, we brush the solid particle off the skin. If it's wet, we do a water lavage. Like you guys remember taking chemistry, there's a water shower right in the lab where if there are an injury, there's an injury, we can just go under the water and just flush it. So if it's a small thermal injury, we cover with clean, cool, and tap water. If it's a large thermal injury, it can affect circulation, airway, and breathing. For the large thermal injury, we have to consider the circulation first before the airway and the breathing. It's reversed. So cool burns no more than 10 minutes. So what that means is that we do not put under the water to cool the burns more than 10 minutes because it is a large thermal injury. If we do more than 10 minutes, the patient might be at risk for hypothermia. So remember that cool burns, we do not run the water through the large thermal injury more than 10 minutes. We do not immerse in cold water or cool with ice pack. The reason why we do not use cold water or cool water with ice pack is because ice and cold can constrict the blood vessel, and we already have a burn injury there. We want perfusion. We want to continuously perfuse the area of the burn. If we use ices on the burns area, it's constrict the blood vessel over there, and there will be no perfusion, which can cause it even more issues later. So please remember that. Do not immerse into cold water or cool water with ice. All right, it may be on the exam. I think I remember a question about it. Remove the burn clothing. Wrap patient in clean, dry sheet or blanket. Next, we have inhalation injury. We have to watch for respiratory distress. And what are the signs of patient having a neck and chest thermal injury? Those are burns, singed nasal hair, or burned clothing around the neck and chest area, or the patient may appearing wheezing or unable to swallow. Those are signs of inhalation injury. Please remember that. Next, we have EKG. VFib is the biggest complication. Usually, EKG and VFib is more to electrical burn injury. The heart is also a muscle, and electrical current can cause a severe constriction of the muscle. The reason you don't want to cool the patient off longer than 10 minutes because you don't want them to get hypothermia. For inhalation injury, if it is suspected that the patient inhaled CO2, start giving them 100% oxygen. We can give through nasal cannula or 100% breather mask. All right, next we have emergent resuscitative phase. This is when the patient experiences severe hypovolemic shock, and this phase will end when the fluid mobilization and the diuresis begins. So remember earlier I say how the patient experience burn injury, they can have a decreased urine output. So when the patient start to produce normal urine output, which is diuresis, that means that the patient is coming out of the emergency phase. Treatment for patient in emergent phase is fluid replacement, airway management, escharotomies. So escharotomies are the removal of eschar. And whenever a skin tissue is burned and is death, it's become eschar. So escharotomy is removing the eschar tissue in order to relieve the pressure for the patient. Fasciotomies. So fasciotomy usually is done whenever the patient experiences circumferential burn. Because of the risk of the compartment syndrome, they need to cut the patient's skin up in order for the pressure to release so that it doesn't affect the perfusion, the patency of the blood vessel. Where am I? Okay. Wound care management. So wound care is a big thing in burns as well. And what is the specific wound care that we need to worry about? We will cover in a later slide. Emergent phase is the immediate life-threatening problem and can last up to 72 hours. The main concerns is hypovolemic shock and edema formation at the end and ends when fluid mobilization and diuresis begin. With hypovolemic shock, capillary permeability increase, which has massive fluid shift out of the vessel. Water, sodium, plasma protein move into the interstitial space, which cause a decrease in colloidal osmotic pressure. It can happen as early as 20 minutes. We'll see hypervolemic shock, decreased blood pressure, increased heart rate, and then leading to death. I think this meant to be hypovolemic shock. Circulatory system is affected by the hemolyzed red blood cell from the burn, so thrombosis formed in burn capillary, which can cause more circulating red blood cell, and as a result, increased hematocrit, causing hemoconcentration. Potassium shift first because of the injured cells release potassium into the circulation, and then sodium moves into the interstitial space, which causes edema. For treatment, we give 100% oxygen, high flow, deep breathing, reposition every 1 to 2 hours, suction as needed, play 2 large port for IV access, and fluid replacement is usually crystalloid, lactated ringers, or colloids, or both. Answer, check on the fluid replacement, check urine output. So we only need to check we only need to give this patient who experienced burn injury fluid first and fluid fast. And the most common fluid that we give for this patient are lactated ringer. Remember that lactated ringer is the fluid to give. And patient who experience large burn, we always place 2 large bore IV for access for the fluid replacement. All right, next we have acute. So this is when the wounds start healing. Begin with mobilization of extracellular fluid and diuresis. This state ends when partial thickness wounds are healed, full thickness burns are covered with skin grafts. Diuresis equals less edema, bowel sounds returned, prevent infection, manage pain, nutrients, wound care. So we check bowel sound because the patient may have been at risk for paralytic ileus. The big goal in wound care is to preventing infection. Nutrients start 1 or 2 days after post-burn diet. After and post-burn diet is high in protein and carb. They need to have protein to promote healing, and carbohydrate is for the energy. All right, so we have fluid therapy, Parkland formula. So we know that these patients really need the fluid in order to resuscitate for them or compensate for the fluid that they lost during the burn injury. So that's why this fluid therapy is very important to remember. So first, with these burns patient, we will need to have 2 IV large bore, and if they are 15 or more percent of the TBSA, remember how to calculate the TBSA earlier. If it come out to be 15 or more percent, the patient will need 2 IV large bore on the side, on the 2 sides. The type of fluid replacement is based on the size and depth of the burn, age, and individual. The number 1 fluid is lactated ringer. That is the fluid of choice. We can also use albumin, but we don't use albumin until after the first 12 or 24 hours. How do we know when to change from LR to albumin? We look at the blood pressure. Is it going up? Is it stabilizing? If the blood pressure rises again, it means the vascular is healing, and that is when we can start switching from LR to albumin. Do they produce urine yet? If yes, it means vascular system is also healing, and that is another sign where we can switch from LR to albumin. Then we can give albumin. Never give normal saline in burn because it can lead to metabolic alkalosis. So please remember this. Do not give normal saline. She may not say normal saline. She may say sodium chloride 0.9%. Do not give it. It's the same thing. Normal saline, and that is the same thing. We only give lactated ringer. We give it first, and then if the blood pressure go up and the patient start producing urine, we switch from lactated ringer to albumin. Does that everything make sense so far, right? All right, here come the crazy part. So it is very important to know the time when the burn occur, because the time when the burn occur play a big factor in the calculation of the Parkland formula, how much fluid we will give to the patient. So the Parkland formula, the formula itself is 4 milliliter times TBSA, total percentage surface area, times body weight kilograms. So the first half of the solution is over the first 8 hours. What does it mean, the first 8 hours? The first 8 hours does not mean that the patient arrived at the hospital and we start counting. We start counting since the moment the patient got the burn injury. For example, the patient experienced the burn injury at 4 p.m. in the afternoon at home. That is the time when we start counting for the first 8 hours. Even though the patient get to the hospital at 2 hours later, we still give the total amount that we would give during the first 8 hours to the patient, even though the patient is late 2 hours. Does that make sense to you guys? Okay. So first half of the solution is over the first 8 hours. The second half of the solution is over the next 16 hours. So for example, we have in for the first 8 hour, the patient need to get 2,000 milliliters, but they doesn't come to the hospital 2 hours into the 8 hours. It doesn't matter. We still give the whole 2,000 milliliter in the 6 hour that the patient arrived. And then in the second half, in the next 16 hours, we then give the second half solution that we need to give to the patient. Fluid resuscitation start at the time of injury, not when we start the fluid. Example, even the patient come in 2 hours late after the burn injury, we still give the whole half solution of the first 8 hour in 6 hours for that patient. All right, how do we calculate it? The first step is we need to calculate the total volume of the solution to give in the first 24 hours. Then we use 4 times the percentage of the TBSA, then we times the kilogram. In the exam, she might give you pound, so that you need to know how to switch from pound to kilogram as well, okay? The total volume of 24 hours divided by 2 will give us half solution. So we use 4 times TBSA times kilogram. That will give us a result of the total volume for 24 hours. And in order to know a half of the total volume, we divide them by 2, then we get half of the solution. And then half of the solution, there are 2 methods that we can use. First method is half solution divided by 8. It will equal the rate to be infused in the first 8 hours. Or half of the divide by 16, the volume will be infused in the second 16 hour. Or we can use total volume divided by 2 is the volume to be infused in the first 8 hour. Total volume divided by 4 is the volume to infuse in the second 8 hours, or total volume divided by 4 is the volume to be infused in the third 8 hours. I would recommend to use the second method. It's easier, and also in the questions, she will ask you guys the second 8 hours, the third 8 hours, or the first 8 hours. So just remember which number you guys will use to divide it, the total half volume that need to be providing for the patient. Okay. So if you guys use the second method, you guys do not have to use the total volume and divide it by 2. You guys just need to use total volume divided by 2 to get the first 8 hour, but to get the second 8 hour, you divide it by 4. You use the total volume, not the half total volume for the second method. And the result should be in milliliter per hour, and the weight must be kilogram. If she give you LBS, please convert it to kilogram. If the patient is restless, it means that the patient is having hypoxia. To determine if patient fluid volume is adequate, we check the urine output. Is it normal to not have urine output in this phase? Yes. The kidney is not ready yet. Kidney trying to convert fluid as much as possible and trying to get perfused. So what we do is we get a Foley catheter into this burn patient. If it's brown and red urine, it is normal and expected because it was a major burn injury. So there might be leakage of blood or tearing injury internally. So brown and red urine is normal and expected when we insert a Foley catheter. What do we access? We access the urine output. When do we concern or call the MD? When the urine output is less than 20 milliliter, acute renal failure. If the urine output is 30 to 50, we're happy, it's good. So remember, if in the exam, any urine output is less than 20 milliliter, that is a priority. You have to report to the MD immediately, okay? Last phase is the rehabilitative restorative phase. This begins when the wounds are healed, patient is engaging in some level of self-care. Skin and joint contractures is the most common complication in the rehab phase. So we need to really consider the positioning, the splinting, and exercising should be used to minimize contractures. What does it mean by contractures? For example, I have a burn in this area. And then as a nurse, if the nurse doesn't help the patient to extend my arms and just let the patient put the arms like this, eventually when the skin heal, this will be stick together and the patient won't be able to move their arm anymore. So that what means by contractures. Exercise is important. Constant encouragement and reassurance for the patient and caregiver. Goal for the patient who experienced burn injury is independence. So range of motion is the major exercise you want your patient doing so that they won't develop contractures. All right, let's touch a little bit on the carbon monoxide poisoning. So carbon monoxide poisoning is the most common airway injury. Inhaled carbon dioxide displaces oxygen, hypoxia, and death when carbon dioxide level are 20% or greater. We need to do a lab test to determine the carboxyhemoglobinemia. Treatment is 100% oxygen and need to get rid of the carbon monoxide. You cannot get saturation on a patient with carbon monoxide poisoning. So what does it mean? This means that whenever you guys put the pulse oximeter onto the patient finger in order to get the pulse ox, the saturation of the oxygen, the pulse ox will read the patient as perfectly fine, 95% and above. Because it doesn't know that the hemoglobin is being occupied by the carbon monoxide. It is not being occupied by the oxygen at all. So that's why the post-op won't give you a correct result. What we need to diagnose or use for these patients who experience carbon monoxide poisoning is the lab test called carboxyhemoglobinemia. Treatment for this is 100% oxygen, okay? Again, how do we evaluate that the patient is having enough oxygen? We check the carboxyhemoglobinemia, and the post-op will not work in this situation. Patient will have cherry red on skin color. Until the patient get enough oxygen, they will lose that cherry color. These are just another slide for you guys to study the sign of mild, medium, extreme carbon monoxide. Fluid therapy, again, touch on them a little bit because it's very important. 2 large bore IV lines for the TBSA more than 15%. Okay, so for example, if the patient burned circumferential 2 arms, it's already 18%. If they have like circumferential right leg, it's already 18% because anterior leg is 9%, posterior leg is 9%. So it's already more than the TBSA of 15%. So if it's more than 15%, 2 large spore IV. Type fluid replacement is based on size, depth of burn, age, and individual consideration. You remember lactated ringer is the #1 fluid choice for infusion to this patient. And Parkland formula is 4 milliliter times TBSA times body weight in kilogram. Learn how to convert LBS to kilogram. Time of injury is very important. Remember, first 8 hour is you divided the total by 2. Second 8 hour is divided the total by 4. And third 8 hour is also divided the total volume by 4. We do not give normal saline because too much sodium, which can lead to metabolic acidosis. The other slide said too much normal saline cause metabolic alkalosis. Yes, I think you're right. Let me think about it. Normal saline, too much sodium, too much. I think metabolic acidosis is the wrong one. It will be alkalosis because it lead to cerebral edema and too much fluid. So it will be metabolic acidosis. The metabolic acidosis is the result of the electrical burn. So thank you for that. Let me write something. It will be alkalosis. Thank you, Juan. Albumin is used after first 24 hours, only after capillary permeability is restored. How do we know albumin is when we can use albumin or when capillary permeability is restored? Blood pressure rises up again and urine output is produced more than 20 ml. All right, wound care. So this is very important to know as well. We need to clean them, shower them daily, even though it's very painful. So that's why we usually done in the morning where they have more energy. We have to do debridement, which is the eschar must be removed. We dress them, we change the dressing, need to be sterile. Infection is the biggest threat to this patient, and enzymatic debridement is the speed up removal of the dead tissue from healthy wound bed. So they can put some medication which have the enzyme which can help with the debridement. When cleaning the wound for showering, give pain medication 30 minutes before the activity. On the debridement, gauze is moistened and covered with antimicrobial agent. So again, wound care is done daily, 3 times a day. Every day they get showered. They shower every single day, excuse me. Dressing changes twice a day and need to be sterile. The biggest threat again is infection. How do we prevent infection from happening? We do not give antibiotic prophylactically. So especially with this burn patient, I remember Professor Lanasa mentioned about this, that we did not give them antibiotic prophylactically because they are at high risk for developing super infection. So we want to avoid broad spectrum antibiotic because we want to prevent super infection. We only give the patient antibiotic whenever we suspect that the patient have infection or having an actual infection. We do not give them antibiotic prophylactically just because they are immunocompromised or they are at risk for infection. Broad-spectrum antibiotic can also kill healthy good bacteria, and when good bacteria die, the opportunistic bacteria can overcome and infect the body, causes super infection. When it comes to wound care, we do soap and water. So this is from my note. So when do we know to give antibiotic? If the wound shows sign of infection or suspect infection, that's when we give antibiotic. Then we do a culture. We put them on a broad spectrum antibiotics. If the wound culture comes back negative, we stop the antibiotic. Only give antibiotic if there's an actual infection. Remember that, please. The ear should be kept free from pressure. For example, do not use pillow because it can prevent their circulation. Any burn area, hands, arms should be extended and elevated on pillows or foam wedges to prevent contractures. You don't want the patient after they heal and cannot move their arms. Must keep perineum clean and dry because they are at super high risk for infection at that area. We use indwelling cath to remove the urine and do perineal care. We need to do routine lab tests of sodium, potassium, white blood cell, CBC, and hematocrit. And we do early range of motion exercises. Splinting will help also with contracture. Analgesic and sedated, we use diluted Haldol and Ativan. And emergent phase drug therapy is these patients are extreme risk for infection. So we give this, we can't give antibiotic prophylactically. I don't know, give this is give what? Oh, okay. We give these. What we give is tetanic toxoid, which takes 2 to 4 weeks to get the antibody. This is active immunity. Or we give immunoglobulin, immediate immune protection, which is IV infusion of antibodies, passive immunity. So instead of giving the patient antibiotic prophylactically, which can result in superinfection, there are 2 methods that the hospital can provide for these burn patient, which is give them a tetanus toxoid shot or give them a shot full of immunoglobulin. So if they give them a tetanus toxoid, it takes 2 to 4 weeks to get the antibody, and this is active immunity. If the hospital determine that the patient is so severe that they cannot provide or produce antibody on their own, they will give them a immunoglobulin shot, which are full of antibodies that already developed and just come into the body and fight off infection. And that is called passive immunity. All right, nutritional therapy, fluid replacement takes priority over nutrition needs, enteral feedings over parenteral, because for paralytic ileus. If the patient have paralytic ileus, we cannot give them enteral feedings. All right, because they are not absorbing or they are not moving. So the content or the stuff that we put them through the enteral feeding will be stuck in the stomach or stuck in the intestine and not move anywhere. So that's why we need to be cautious patient with paralytic ileus. We will give them a diet full of high protein to promote wound healing, and high carbohydrate to meet the high demand of metabolic demands. With nutrients, watch for fluid overload, and internal feedings, watch for, I think that means enteral feedings. Watch for hyperglycemia, check glucose for check glucose, and for paralytic ileus, you will be listening to bowel sounds and making sure they are using the bathroom. Oh, I hate that they don't have any comma or anything. But yeah. And that's it. That's the last slide for this lecture today. And next week we have oncology. Before we end the tutoring today, is there any questions or any comments that you guys would like to share? I hope it was helpful and it was not too long. You're welcome, guys. Thank you so much for coming, and I hope it was helpful. Just one more chapter, oncology, and then exam 3. And then, wow. Thank you so much. And then you guys are going to be 4th semester. How exciting. Ready to, I know, me too. Oh, this semester was just insane. Thank you for coming, guys. Thank you. I hope you guys enjoyed it. I'm gonna stop the recording now.